Hi, everyone. Thank you so much for coming to our webinar today, which is focused on clinical supervision best practices and the recently published CoLab Supervision Guide. Today's webinar will explore best practices and common challenges in clinical behavioral health supervision and features a panel of wonderful Washington-based supervisors. So I'm noticing that there are a lot of folks still coming in, so we're just going to wait a few minutes before we officially start. And while you're waiting, we would love if you could fill out the poll that's going to pop up on your screen in just a minute. And that way we can just get a sense of who's here and kind of what fields you're coming from. We'll just give it about one more minute before we officially start. All right, I think we have a pretty good group here to start. So good afternoon, everyone. My name is Anna Duncan. My pronouns are she, her, hers, and I'm a program operations specialist here at the CoLab for Community and Behavioral Health Policy, and also the Evidence-Based Practice Institute. On behalf of our team, I want to thank you so much for being here this afternoon, especially on a Friday. We're really excited about today's webinar, which, as previously mentioned, will provide an overview of supervision best practices and resources outlined in CoLab's recently published supervision guide, along with featuring an interactive Q&A session and broader kind of panel presentation from current behavioral health supervisors in Washington. So to begin, we'll start with the land acknowledgement. CoLab for Community and Behavioral Health Policy and the University of Washington acknowledge that we gather on Indigenous land, the traditional territory of Coast Salish peoples, and specifically the Duwamish tribe. This ancestral land is unceded and must be returned. We also acknowledge that our work across the state takes place on the homelands of Native peoples who have lived in this region from time immemorial. Currently, there are 29 federally recognized and 7 non-federally recognized tribes within Washington state. We express our deepest respect for and gratitude toward these original and current caretakers of the region. As we move forward in advocating for and moving toward health and racial equity, let us remember that we are living in a history-driven present. Let us work to learn more about the histories, cultures, and traditions of Indigenous people and how we might build relationships with sovereign tribal nations and create more inclusive spaces that foster innovation, collaboration, and empowerment. We encourage you to consult native-land.ca to learn more about the land that you are on and to pay rent through Real Rent Duwamish. The Duwamish tribe has yet to be justly compensated for their land, resources, and livelihood. And by paying real rent, you can do something today to stand in solidarity with First Peoples of this land. All funds go directly to the Duwamish Tribal Services to support the revival of Duwamish culture and the vitality of the Duwamish tribe. Before we begin, I'd like to do some brief Zoom housekeeping. So if you encounter any tech issues during the webinar or generally want to express any thoughts or reactions to our speakers, please feel free to send a message in the chat box. We really encourage, oh, thank you, Justin. Really encourage you to put kind of reactions, thoughts throughout the presentation in the chat box. We will have a Q&A session at the end of the presentation, so feel free to pop your questions directly into that Q&A box that should be at the bottom of your screens, and then we'll have a bank to pull from at the end during our Q&A portion. Lastly, you'll notice that this is a big Zoom meeting rather than a webinar. That way we can actually see your faces, which we really love because it's more interactive, but it also means that sometimes you can accidentally be unmuted. So we just ask that you please pay special attention to making sure you're muted unless you're specifically called on to speak by a presenter. So thank you so much. And also as a reminder, we will be recording this webinar and it will be uploaded to our website and our YouTube page. All right, so at the end of this webinar, we will send an evaluation survey link through the Zoom chat. We would love it if you could take some time and fill that out. This really helps us improve our future webinars and gives us feedback on what went well, what you would like to see differently, and also future webinar topics that we might focus on. We will also be sending out this link after the fact through an email listserv, and you'll also get a recording of the webinar as well. So thanks so much in advance for giving us some feedback. Additionally, we also, once you filled out a survey, you'll be able to get a free certificate of completion so that you may or may not be eligible for credit through your field-specific continuing education organizations because they all have different policies, but we're happy to provide you with documentation of attendance and completion of this webinar. So before I turn it over to our presenters this afternoon, we're going to just take a quick look at our live poll results. So it looks like, unsurprisingly, we have about 80% of you are mental health professionals, with then a smattering of folks kind of spread across policy, healthcare, research, and advocacy, and then about 25% specifically in social work. So really happy to see you all here today. We're really grateful you're sharing this space with us. All right, so for those of you who are joining us for the first time, the CoLab for Community and Behavioral Health Policy was founded in 2020 in the Department of Psychiatry and Behavioral Health Sciences at the University of Washington School of Medicine. And just to provide some really brief background on what we do, the CoLab engages community expertise and research evidence to spark creative and sustainable change in behavioral health policy and systems, particularly those involving youth and families. The Evidence-Based Practice Institute, which is housed within the CoLab organizational umbrella, was established in 2007 by the Washington State Legislature to promote high-quality mental health care for children and families. So again, I want to thank you so much for being here. We're really excited to have this webinar, to have you here today. So next, if we could go to our next slide, please. Just to give a brief overview of our agenda for today. So we're going to start with introductions of our amazing panelists. We're going to provide a brief overview of the Supervision Guide resource, and then there will be some questions that the panelists will speak to around common supervision challenges. Then we'll move into case scenarios and then have a lot of time at the end for question and answer. And then we can go to the next slide, please. Thank you so much. So for today's webinar, we're excited to feature a panel of 4 amazing Washington State behavioral health supervisors. So I'm just going to give kind of a brief introduction for each of them. So our first panelist, Louisa Hall, has been a supervisor and clinician at Sound for 20 years, working with children and families. She's been involved in the CBT Plus training initiative, doing live trainings and consult calls for clinicians around the state. All of her supervision work is focused on supporting the use of CBT by clinicians in community health. Our second panelist, Naomi Leong, is the clinical director for Frontier Behavioral Health. She's a CBT Plus supervisor, regional trainer, and has led consult calls. Naomi's private practice specializes in serving transgender and gender diverse individuals. She holds a certificate in diversity, equity, and inclusion, and is working towards certification with the World Professional Association of Transgender Health. Our third panelist, Minu Rana Stewart, is the Director of Student Support Services for Puget Sound Education Service District in Renton, Washington. She provided training to mental health providers across Washington State on evidence-based mental health treatment models for children and adults, participated in clinical research projects, delivered trauma and trauma-informed trainings to the community, and provided direct clinical therapy services to children and adults with a keen interest in treating race-based traumatic stress and ensuring race and identity are included as essential and necessary aspects of prevention, intervention, and therapeutic services. And then last but not least, we have Stacy Remy, who is a licensed mental health counselor in Washington State with over 15 years of experience working in behavioral health. She's worked with children, youth, and adult populations of diverse backgrounds and specializes in treating trauma, depression, anxiety, and behavioral concerns using evidence-based practices. For the past 2 years, she's been a CETA consultant contracted with Harborview, supervising newly trained up-and-coming CETA clinicians. She's also worked in community mental health for 14 years and became a clinical supervisor in 2013. And Stacy began her own telehealth private practice in May of 2022. So with that, I will hand it over to our facilitator and my colleague, Dr. Georgiana Sedlar.
Thanks so much, Anna. Welcome, everyone. Like Anna said, we're just very pleased about the interest in today's webinar. You know, we recognize how much all of you have going on at your workplaces. And as Anna noted, you know, that you're dedicating time on a Friday, and I would add on a Friday of the lunch hour, no less, to be here today. And I think really the number of you speaks to the level of interest in the topic and really points to the need for supervisors to have support, guidance, skills in the critical role that all of you are playing to ensure that providers are delivering, you know, safe and effective care, and really by extension protecting the welfare of clients. So just to briefly tell you who I am, I'm Georgiana Sedlar. I'm a child clinical psychologist and on faculty in the Department of Psychiatry and Behavioral Sciences in the School of Medicine at the University of Washington, Seattle. And I'm part of the CoLab team that Anna noted earlier, and we support you know, different initiatives throughout the state that partner with community providers and organizations with the goal of improving behavioral health care for youth in Washington State. I also just want to note too, I serve as Director of Clinical Training and Community Engagement in a master's program in applied child and adolescent psychology that's offered through the psychology department, also at the University of Washington in Seattle. And my role there, I mentioned that because it's really given me additional really close-up opportunities to see how essential supervision is to clinical skill development and really helping to prepare a well-trained behavioral health workforce. So again, just so grateful that we're able to do this today. Now I'm going to talk about the slide that's on deck here. So the process I think is important, just briefly to describe how we got to this point of developing the guide. You know, as we noted about CoLab, is a priority is really this community academic partnership, and I think this guide really reflects that nicely. We first, and the graphic will sort of walk you through, but you know, we convened a group of supervisors, an advisory team, some of which are on this very call, and we wanted to hear about challenges and needs. And so after a lot of discussions, we landed on kind of a first step would be developing a guide like this as a initial resource. This process was really iterative, and I think that's an important part too, is that we worked with our advisory team on identifying, you know, key content, key sections, and we continued to meet to refine those. And then we were also really fortunate to have additional community partners who had supervisory experience that provided input on parts of the guide having to do with trauma-informed practice and cultural humility and responsiveness in supervision specifically. So just really grateful to all of them, and would not have been able to develop this guide without them. And then finally, we asked additional content experts to review the guide and went through another round of edits. So we landed at the current version, which was widely distributed across different behavioral health organizations and partners just a couple months ago. So let me, if we can go to the next slide. And yeah, just do the first one, Joanne, and then I'll kind of prompt you when I move on to the next one. So, you know, we really think this resource will be most useful for those it's really intended for, you know, supervisors in community behavioral health, those who are supervising clinicians and using specific clinical elements. We really recognize that supervision, while there's overlap in the skills you need in providing therapy, it's really a distinct and separate skill set. And oftentimes those supervisors are not, they don't have training, right, on how to transition from a provider role into a supervisor role. So this guide is intended for supervisors who maybe be stepping into that role, you know, for the first time, or who have been a supervisor for a considerable amount of time. And I think we maybe have an audience that reflects that continuum. So just to orient you to the key sections of the guide, and really want to encourage you to, you know, take a look at it if you haven't. The first one is just recognizing that supervision is an interpersonal relationship. And so much like the therapy relationship between a client and a clinician, there has to be, you know, safety, acceptance, empathy, trust. And so this section talks about ways to support an environment where those can occur. And then do you want to go to the next one, please? Thanks. So structuring supervision, you know, a lot of supervisors, like I mentioned earlier, have been promoted to positions without much guidance or training on how to do supervision. And so oftentimes we rely on sort of, well, how was it done? You know, what did we like or didn't like about our supervisory experiences? I'm sure we can all sort of think of both. And so it can also be tricky navigating when you're moving from a peer-based relationship with your colleagues, right, to now stepping into a supervisory one. So this section was intended to provide guidance on how to set the stage for a solid working relationship with your supervisee, ensuring that there's a shared understanding of what supervision is and what it isn't. I think is really important, you know, your particular approach to supervision and expectations. I think getting that up front is really key to setting sort of the stage for a good working relationship with your supervisee. And then the next one kind of segues into then, once you've established this shared understanding about what supervision is, how it's going to go, it talks about specific practices that we know have been shown to be effective in supporting skill development and supporting skill acquisition in clinicians, particularly modeling active practice, you know, having a format for supervision. So that's that section. And then the next section, if you can go to the next line, supporting supervisees with trauma exposure and vicarious trauma. I'm sure you know, these are things that everybody is probably aware of and has experienced, is that it's, you know, we know trauma exposure is common just in the general public. And then it's especially common with community behavioral health, in community behavioral health settings, and that includes providers. And so while this doesn't necessarily mean that everybody who's had trauma exposure is going to sort of encounter difficulties or challenges in their clinical work, I think it's important to have this, you know, on our radar and be aware of that providers might be particularly susceptible to compassion fatigue, vicarious trauma, burnout. So really important to pay attention to this. And this section covers sort of core aspects of how to support clinicians in those. And then the next one is supervision of specific clinical components. So, you know, it's been shown and widely agreed that active supervision is necessary for successful implementation of quality treatment. And so this section gives some guidance on how to supervise on specific clinical practices to really help ensure that clinicians are being able to implement specific clinical elements. And then finally, common supervision challenges. It reviews challenges that supervisors might face around helping clinicians implement specific components and offers suggestions about possible helpful responses. So then if you could go to the next slide, then at the end of the guide, and this is just a screenshot, so this isn't everything, we just wanted to give you an idea. And for those of you who've already maybe looked at the guide, you've seen that we have these hyperlinks. So as you're reading throughout the guide, it can hyperlink you to these resources at the end of the guide, or you can just go straight to the end of the guide and look at these resources, but they're linked to different resources related to each of the content area that I just reviewed. So they have like sample supervision contracts, resources around cultural responsivity, best practices for supervision, therapist wellness resources, things like that. So our next steps are to create some, distill down this larger guide into some need to know resources, kind of like a 1 to 2 page cheat sheet, if you will. And then we're also developing an online training that is in alignment with the key content areas of the guide and would satisfy the Washington State requirement for supervisor training. So that's just a little sneak peek of what's coming next, and stay tuned for more about that. So now I'm so excited to hear from our panelists, and if you could advance the next slide. So, and I want to thank all of you who, when you registered, there was a question around what are you interested in? We really wanted this to be sort of relevant to the people who were attending. And so we really thank you for helping inform some of these questions. So now what I'm going to do is I have 3 questions that really emerged, seem to be of great interest, and from all of you. I realize these are not, this is not the only burning topics, right? And we have time reserved at the end to talk more either about these questions or about other ones. But if you can go, so what I'm going to do is I'm going to pose a question and then ask our panelists to just raise their hand as they see fit and as they want to sort of weigh in on these questions. So let's start us off with the first one. If you could advance the slide. So, I will say I was not surprised that this emerged as, I would say this was the hot topic of what we heard from all of you as you were registering. It's not surprising. I also, in my different sort of work activities, hear this over and over, that I think particularly, that burnout and attrition has always been a concern in community behavioral health. And I think it's just been really amplified over the last few years. So we know that burnout among clinicians and impact on retention has long been a challenge within community mental health. And like I said, it's now more pervasive than ever. And we know there's a cascading effect of burnout and turnout ultimately on the quality of care and client outcomes, right? So a question that we'd love to have the panel address is, how can supervisors mitigate clinician burnout and encourage retention? And what specifically can supervisors do to support their supervisees' well-being and promote their work in community mental health? So I will just let people kind of digest that question and invite our panelists to answer. And I see Naomi is first up. So Naomi, we'd love to hear from you.
Sure. So one thing that supervisors can do is to create a safe space to have conversations about burnout, because there can be some stigma attached to the concept of feeling burned out. And so if you carve out time in individual supervision or group supervision to just normalize talking about it, that can help, because individuals may be feeling that if they're experiencing burnout, maybe they're weak, or maybe they lack professionalism, or they shouldn't be in the field, or they lack readiness to be on the job. So if we can create a safe space to talk about it, we might be able to find out that there's some causes to it that we have some control over, and we can make some changes that might help lessen those feelings of burnout.
Yeah, I love that. Thank you so much. I think normalization is just so key. Just like we normalize a lot of things with our clients, right? As providers, right? I think that's great. I also see, let's see, who else is, I lost my, oh, Minu.
I'm going to take a little bit of a larger approach to answering this question. So I think supervisors are in a unique and special situation to be able to advocate on behalf of their staff to leadership. So when we're talking about, for example, normalizing, what are we doing to normalize stress and burnout within the leaders, or with the leaders of our agency? And then, after that, what are we then doing to, this is a little, a term I coined, what are we doing to institutionalize wellness? I think a lot of times conversations happen, as they should, on the one-on-one level, and really reminding, the folks who teach people about self-care to also do their own self-care. But we have to really stop and ask ourselves too, what are our agencies doing to normalize, stress, burnout, to make space for institutionalizing that wellness, right? So what are we doing to create the culture or climate to take care of yourself? And again, that, I think as mental health providers, sometimes we're drawn to like mental and emotional aspects, but what are we also doing to, take care of our physical and our financial well-being? And so there's, lots of ideas that can go with it. How do we make our staff feel like they belong and they're recognized, right? Kudos, success stories, affirming when collaboration happens well within agency, allowing staff to be part of problem solving when problems are identified, to just give them that ownership helps with retention. So I'll pause there. I'm sure there's lots more great feedback from the other panelists.
I love that, Minu, taking that broader perspective and at the organizational level. And I wrote down that term, institutionalized wellness. I love that. I'm going to have to steal that, I think. So thank you. Stacy.
Sorry, thank you. So burnout, as Georgiana said, obviously, everybody can hear me, right? Obviously is a really big one in mental health. And I've seen tons of ideas thrown around over the years about how to decrease burnout and increase retention. And managers have come up with these like bold ideas. If everybody meets their productivity standards this month, we all get a pizza party. And pizza is nice and all, but I doubt the effects of that last much past the lunch hour. Joke. But true, right? I mean, though I don't think that that's really where it's at. But I always take the word burnout very seriously if it's uttered by one of my supervisees. And I've found that added support is the only thing that helps my supervisees the most, and may convince them to stay. So I just stop and listen. I want them to feel heard. I want to get to the bottom of their burnout. Why are they feeling burnt out right now? Are they having trouble at home? Are they going through a divorce? Are they struggling with insomnia? Are they dealing with the illness of a loved one? Do they have a baby, toddler? Do they have a teenager that's out of control? When was the last time they took a vacation? Have they been dealing with a lot of trauma in their sessions? How's their caseload size? What does their paperwork load look like? Are they drowning in paperwork? That's what I like to call it, drowning in paperwork, because that's literally what it feels like. When was the last time they took a lunch break? And then I asked them to share, what do they think is going on in their own words. And then I make sure to let them know that burnout is so very common. And then praise, 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 because when people are feeling burnt out, it's really important to remind them that they're good clinicians and that they have successes. I think it's really easy to forget that when you're feeling burnt out. I always give them the EAP paperwork and encourage them to use it, just as one thing that I do. But then I ask them what would help. What do they need? Do they need to take a vacation right away? Do they need to block out time in their schedule for paperwork? Do we need to look and see if we can delegate some things to case management? And I let them know that we can meet more frequently if they need to. And then I check in with them. And then I check in again. Because usually burnout is not something that passes overnight or in a week or two. So, but then on the bigger picture as an agency, I think just supporting self-care is where it's at more. Having meetings just to catch up and talk with no other agenda, like offering lunch walking groups during the summertime, sending a reminder to stretch YouTube video to their email box, or putting a bottle of water outside their office door with a smiley face sticky note, drink water. Having a thank you box and using it, or like talking about successes in supervision and in all staff meetings, because I think successes often get forgotten. And then encourage the work-life balance talk in supervision, and not just after they've used the word burnout, but like throughout supervision.
Wonderful. Thank you so much. I just so appreciate the thoughtfulness around all of this. And Louisa.
Thanks. Yes, I agree. Such great ideas on different levels. Maybe one that hasn't been touched on that or that much that I think is really important as a supervisor is the environment within the team. I want to not be the only place where people can talk through what's going on. I want there to be a supportive environment that coworkers can talk to each other, that there's a safe place to talk about things. And so we've done a few things in team meetings. We've had regular conversations around kind of scheduled times once a month where we talk about self-care. We showed Laura Van Dernet Lippett's the trauma stewardship TED Talk, and we all spent some time talking about that. I think we've also been working on creating just some more ownership of the space. Things had kind of changed during COVID, and as people are coming back, we're kind of thinking about where do we want to make any changes? Do we want to have some space where we hang client artwork, or we share some other way of kind of having some ownership over the space and the office and the team and itself. And then I think one other thing that I've been really trying to encourage clinicians to do as we're looking at serving bigger and bigger populations, more and more people, there's more and more need. One way we can serve more people is by doing groups. And I think if we can get clinicians to bring things that they're passionate about in their regular life, things that they do for self-care in their regular life, and bring those into groups that they can create a group around that, I think that's can be a really invigorating process. And so we're all kind of working together to create this curriculum of groups. And it has been really great to see what everybody's bringing to the group. And it gives, again, some ownership over things that are going on. Like Stacy said, there's a lot of paperwork, there's a lot of things that need to happen. And so when we can find ways as a team to create some ownership over things we have control over, I think it's been really helpful in mitigating some of the burnout.
Thanks so much, Lisa. I love that. You know, I'm kind of hearing this recurring theme around like, what are the things, you know, there's a lot of things outside of our control, right, at work, especially in community behavioral health, but this idea of like empowerment, right, giving some ownership, having the, you know, people feel like they're being valued, they're being listened to, they're being valued in a way. It doesn't have to be, you know, we'd love to be able to give raises, right, to everybody. And that the reality is that's not always the case, but this idea of like ownership, empowerment, that they have some control, I think is just such a wonderful and I think easy, you know, easier lift to do. So thanks. And Naomi, you have some additional thoughts. Would love to hear them.
Yeah, another strategy that we've used that is pretty simple, and fun, and it's been really effective, and I've loved just seeing it kind of spread. And this is the concept of peak moments. So we've talked about how it's important to intentionally try to notice the positive things that happen throughout the day, and they could be little things or they could be big things, and we're calling those peak moments. And we can share about those just passing in the hall or at lunch or during staff meetings if people have peak moments. And it could be really little things like, wow, my client made this huge step in progress today, or it could be something interpersonal with coworkers. But by intentionally focusing on the positive, it makes sure that we're noticing it, because it can be really easy to overlook the positive stuff that's happening and to just feel like everything is stressful, and that's just not the case. So if we intentionally focus on the positive, call it out, share it with others, then that expands that experience. So not only are we having the positive peak moment, but we're sharing it and spreading that.
I love that. Yeah, I think we could spend probably the entire time talking about this issue. I really appreciate how top of mind it is. Before we move us to the next question, just also what I'm hearing too is what always strikes me is just the parallel process, right, that exists, like the things that we're, you know, wanting, you know, that we're wanting our clinicians to do with clients, right? That we should be doing with our clinicians, right? There's supervisors to supervisees, right? So there's this parallel process that a lot of these things that we're talking about are not new to us, but maybe in terms of who's doing them. So appreciate this conversation. Like I said, I think this is something that obviously we could keep talking about, and seeing people are resonating to a lot of what you're saying. Could you go to the next question? So again, this is another topic that we're not, you know, we could spend the whole webinar time on. But again, another one that really rose to the top around what's on people's minds. So inherent in the supervisor-supervisee relationship, right, is this power difference that can bring up feelings and inhibit open communication. And then if you add to this relationship that often supervisors or leadership don't reflect the workforce that they supervise, that can really, the supervision process can be impacted substantially. So this is kind of a two-parter. What are unique considerations when supervising clinicians of color and or clinicians that hold minoritized identities? And then again, what would you recommend to a supervisor who may hold privileged identities working with supervisees who hold minoritized identities? How can supervisors affirm them? So again, just going to open it up to our wonderful panelists and see what you have to say. Minu, take it away.
Okay. Again, so many parallel processes here. You know, as we've been talking a lot about, you know, opening the door for our clients and seeing if they're willing to come through to start a conversation with us about, you know, their race, their identity, and how it plays into the reasons, you know, they're presenting. It's very similar. I think that, as supervisors, we need to open that door to allow our supervisees to express to us how their identities play into who they are, what they're experiencing when they're doing their work with their clients, but also how that plays into what they need from us as supervisors. So, again, sometimes just putting it out there, whether it is a very observable identity difference or even when there's not, right? Because there's all the, invisible isms that happen with people. So again, just creating that comfortable space and opening the door and allowing the clinician to walk through. The one thing that I will, again, the panel is made up of amazing supervisors. One tip I will give is to listen for understanding. So when you're in a supervisory process, and let's say you're talking about something that happened in a session or you're going through a decision-making process, really be thoughtful and listen for understanding. I think a lot of times when you're working, let me rephrase this, people of color, including myself, often struggle with perceived incompetence. It is the unfortunate reality that we have to deal with. And so I think that when you are in a supervision process with a person of color, particularly, but also definitely other marginalized groups as well, is again, listening for understanding and asking for understanding. Don't ask it as a way of kind of planting an idea or questioning what they did. We're already dealing with that every day, all day, all the time. So just be thoughtful about your intention when you are asking.
Thank you, Mina. I love that. Listening to understand is so great. And opening the door, they may choose to step all the way through or take a little step but you've opened the door and hopefully can come back to that if needed. I think keeping that conversation going and showing that openness. Really appreciate what you said, Minu. Let's see, Stacy.
Oh, I'm still unmuted. Good. Yes, as supervisor in general, I believe that we need to be open and kind and caring and a good listener. And I like how Minu said, listening for understanding. And we need to be aware that there are cultural differences. I honestly wish that there was so much more talk and training on trauma-informed supervision and how race, culture, and ethnicity can affect power dynamics and supervisory relationships when I was a young supervisor, because I must admit, I don't think that I always did a good job of this when I was a young supervisor. It just wasn't trained. I didn't know what I didn't know. And cultural competence, as they called it then, was part of my annual training as a clinician. But it didn't have the same impact as the discussions that we're having today. So I worry my awareness was not at the level it should have been. And looking back, I'm sure that there was missed opportunities for connections with my supervisees of color. I've tried to fill that gap as best I can, and I understand that it's a forever learning process, and I'm committed to that reality. I'm aware of it. I talk about it now. I bring it up. I reached out to a supervisee that had left the agency a while ago, but we had maintained a nice relationship. But I brought it up and we talked about it. I'm not going to share what we said, but I will say that the conversation was very meaningful, I think, to both of us. And once you start talking about it, it does get easier. And there's some really nice guides to get you started. And so on another note, I was once put in a supervisory position with a male who was 30 years my senior. And while I kept a very straight face, imposter syndrome was all I felt inside in that dynamic. But luckily I knew him pretty well. And he liked to joke that he was working at the agency when I was in diapers. And I know, I know how that sounds. But trust me, he didn't mean anything malicious by it. He just liked to joke about his age and how he was still working. But he and I did talk about our gender and our age differences and the fact that I was his supervisor. And he said he was glad that we had that conversation. And I was glad that we had that conversation too afterwards. And when he did retire, he told me how much he respected me as a supervisor. And he said that I helped him out of a few really tough situations. So I thought that was an interesting experience too to bring up.
Thanks, Stacy. Yeah, it really goes. I like just to emphasize the, ongoing learning, that's part of sort of that cultural humility, I think, is being open to sort of, we're always learning. And that there's a difference between intent versus impact. Maybe think of your supervisor. Naomi.
So this kind of goes along with what Mina was saying, talking about that, really trying to get that understanding. I think it's important for supervisors to keep in mind that simply having a voice or feeling like you have the right to speak up or, be your authentic self or advocate for oneself, that in itself might be a byproduct of privilege. And so as supervisors, we need to make efforts to make sure everybody truly has the opportunity to speak. And that's the only way to create a genuinely inclusive environment, or at least, make our best efforts towards that. So some minority and marginalized folks may not contradict an authority person. It may not feel safe, or it may not feel respectful. And folks might just go along with things or laugh it off when something may be truly bothering them. So a couple strategies to try to widen the circle and make sure that we're honoring everybody's strengths equally is when we're asking folks to share in a group, instead of just saying, hey, does anyone have anything? We could do a round robin, which gives everybody a chance. Or if that isn't working, give everybody a sticky note, have them write down their thoughts, and then they could put them on a whiteboard. There'll be no names attached, and people might feel like it's safer or a better process to be able to share that way.
I love those. Thank you, Naomi. Yeah, it doesn't always have to be big, huge, grand things, but I love those ideas for inclusivity. Louisa.
Thanks. Yeah, these are, like you said, really great ideas, and I don't need to repeat them, but I do think I love the ideas that Naomi was sharing about bringing voices to the table and making sure there are ways to make that happen within that environment that can be safe for everybody. I think that, like Mina was saying, the parallel process is great here, and maybe with all of these topics around, we want to make sure that our clinicians are having conversations about race and racial trauma with their clients, and so we need to mirror that. And sometimes that means it won't always be perfect, but there's always learning to be done there. And so I think continuing to focus on that and bringing it up and opening the door is such an important piece of this conversation, and models really what we're hoping for our clinicians to do. I'm just going to share a resource that I like to share with clinicians that I think is really helpful. It's from the advanced CBT training from a couple years ago from Dr. Aisha Messenger. And here is her website, which is just great and really useful for helping clinicians and opening the doors for ourselves as well.
Thank you so much for bringing that up, that resource up, Louisa. Yeah, Aisha Metzger is just an amazing, phenomenal person. And she's actually been, the CBT Plus partnered with her on developing a resource for clinicians, and Minu was also part of that too, really instrumental in that, and in this conversation, in opening the door, how to have those conversations. And again, just going back to modeling, I think that's so important, right? Is like, what are we doing as supervisors, right? That is modeling what we are hoping hoping clinicians do with their clients. Like, it has to start, starting with us is really important. So appreciate those points. All right, so why don't we move on to the third question, that we want to get to the case scenarios. Oh, and Nat, so Nat, I didn't realize you were on. I also want to give a shout out. Nat was also instrumental in partnering with Aisha Metzger around that resource for CBT Plus clinicians as well. So, and thank you for sharing that. I believe, Nat, that resource you shared is also in the supervisor guide resource. So I want to encourage people to look at those resources that are hyperlinked in the guide. And this is also giving us sort of, we're going to do another iteration of the guide. And so we'll definitely taking notes around things we need to add. But yeah, I think that's in there already. So that's good. We're getting some converging evidence here. So the last question before we go to the case scenarios. So it's important for clinicians to use effective practices with their clients, and yet clinicians often report not wanting to feel stifled in their work with clients, or feel like their individual style is being stifled. So in your supervision practice, how have you balanced supporting clinicians in learning and using, evidence-based, evidence-informed practices while incorporating their own style and identity? What are the main challenges you've encountered when balancing both, and specific recommendations you have to supervisors dealing with a similar situation? All right, and Stacy is first out of the gate on this one. So Stacy, we'll hand it over to you, and then Louisa.
I think I would just go first because I have the easiest response, just because I was fortunate enough to work at an agency where this was not much of a challenge, because we only hired individuals that were open to evidence-based practice and understood that we used EVPs exclusively. So they agreed to that at hire. But despite this, we had many, many talented and creative therapists that thought outside the box while, staying true to EVPs with fidelity. So I had a therapist that was an art therapist, and she did art with her clients at nearly every single session and did amazing work with her clients. I had one supervisee that loved systems theory and found family genograms to be highly effective in learning about family dynamics, and he completed family genograms with almost every client. There's a lot of systems theory in the work that we do. I had another supervisee that was trained in sand tray therapy and loved this modality. And so she incorporated sand tray therapy into her work with EVPs. And I just wanted to say that EVPs aren't as rote as sometimes people think they are. And there's a lot of room for creativity when you're delivering them. Everyone has their own style, their own personality, the way that they relate to people, but it just has to fall within certain guidelines and the messages that we bring across. And that's all. So that's all I had to say.
Thanks so much, Stacey. Louisa.
Yeah, I have an easy or a little bit of an in too, because my training, my master's degree is in expressive arts therapy and mental health counseling. So I came from a place where we did a lot of things came through art. And I think the thing that I try to talk to clinicians about is, like Stacey said, it's not as formulaic as people kind of have the idea of, or at least used to. I think it's changing a little bit, but it's not as formulaic as it used to be. And I think, Sandtray and art, those are all languages that we're going to use with our clients, right? A kid is not going to sit down and talk, 8-year-old isn't going to have a 1-hour-long conversation about their thoughts without having some other way of talking about it, and actually using those other types of languages like art can even deeper the meaning and understanding. And that might be the expressive arts therapist in me saying that you can, each modality can deeper the understanding and the internalization of that. But I like to stress that it's not really an either or, that they can, the style and what the clinician brings to the work is so important. And really helps enhance the EBP.
Thank you so much, Louisa. Minu.
So my response is going to be tailored maybe for situations where you're supervising newer clinicians. I think one of the easiest places to help new clinicians bring their style and flair into therapy is through analogies and storytelling. So, in CBT plus training and CETA training, we use a lot of analogies to get buy-in, right? For example, emphasizing the importance of skills practice. And I know, there's the analogy of the Titanic. Would you rather, learn how to swim in a warm heated pool or when the Titanic is sinking? Now, the Titanic may not be culturally appropriate for everyone or generationally appropriate for everyone. But I think this is where the conversations with your clinicians about, when you are engaging clients into, the importance of a new skill or a new process in therapy, what would you want to share with them? Another thing, analogy or storytelling, it could also be some self-disclosure. I know people get a little bit nervous with self-disclosure, but when it happens right, it can be extremely powerful. I sometimes use self-disclosure. For example, I have used it when teaching people about what exposure therapy is. I share my experience with getting into a pretty serious car accident years ago. Some self-disclosure I use when teaching relaxation skills is I'm Indian American and Diwali is a big holiday in my culture. And I imagine blowing out diyas, which are the brass tea light holders. So, I think an easy place for new clinicians is starting to figure that part out. And then the other stuff, right? All the other creativity will come as they learn and get more comfortable.
I love that, Minu. Thank you. Yeah, appropriate self-disclosure. Again, thinking of parallels with clinical work. And Naomi.
This is a challenge that I haven't run across at our agency. We have the opposite challenge where staff are really clamoring for wanting training in EBPs. And I think that's because when they see how effective they are and they see their clients making good progress in a shorter amount of time, that really can help with some of that hopelessness and helplessness that can go along with those secondary trauma, compassion fatigue situations. And so happily, we don't have that at our agency. We are just trying to give people as much training so that they feel competent and confident to work with our clients.
Thanks, Naomi. Yeah, and there's some research that supports when clinicians use evidence-based practices, it actually wards against burnout and improves retention. So thank you for sharing that. I want to, it's been such a great conversation, and we have another great round to get to. I want to make sure we do. So if we could, we're going to pivot now to some case scenarios. And what I'm going to do is I'm going to turn, so the first scenario is going to be Naomi's. And before we get to this section, just want to say that some of these scenarios that we're going to present, permission was granted by the provider to share the actual sort of scenario. Others are reflect more of a composite sketch. So these reflect, they're not a specific case, but they reflect a composite of different supervision scenarios that illustrate some salient supervision topics. So want to put that at the outset. And I'm going to, our first question is going to be Naomi's scenario that she's going to talk about. And then we'd love to, before Naomi talks about what she did, would love to sort of invite audience to share, thoughts, observations, kind of what they would, what they might do before we hear from Naomi. So we could go to the next slide for the case example. So Naomi, I'll just let you take it over.
All right, so I did have permission to share this scenario, and this has happened really recently, about 3 weeks ago. So in this scenario, I was only leadership on site, so I was providing coverage. So I don't work directly with this clinician, but I'm familiar with her. So she's a master's level provider who's been in her position for 9 months. And she knocked on my door, and I was actually on the phone. And so I kind of did the phone gesture, and then she was still knocking. So in my mind, I'm thinking, uh-oh, like what's going on? And so, asked her what's going on. She comes in, I could tell right away, she was very stressed out, said that she had a client in her office presenting with manic symptoms, and immediately said, kind of threw her hands up and said, "This is above my pay grade." And I have to admit, I had a pretty strong writing reflex at that moment, but remained in equipoise. And since I'm not familiar exactly with what her skill and knowledge level was, and I could see that she was very stressed, I decided to approach it by just giving very specific instructions. I did not make any moves to do it for her, which is what she was wanting. She was wanting me to go take care of the client, but I gave very specific instructions. I determined this wasn't the time to kind of puzzle it out with her and say, what do you think you should do? We really have to match our approach, I think, of how we're supporting, and not have a one size fits all, because we need to be dynamic with it, depending on the situation, depending on the staff. So I gave very specific instructions, let her know I was available if questions came up. We use Teams chat a lot in these situations, so she could communicate that way. I also walked back and forth by the office several times just to make sure things weren't escalating. It was very quiet, so I assumed that she didn't need any additional support. And what was really important is later we debriefed how it went. My staff said that was really important. And I asked her for her feedback of this experience. And she said at first that she felt really nervous and over her head. But after talking with me, even though she was still feeling nervous, she felt like she could go handle it. And processing afterwards really put it into perspective. She thanked me for not coddling her. And, I do feel like that experience built confidence. She was able to work with the client, and it resolved very nicely. So is there anything that anybody would do different in that situation? Have you encountered something similar?
So people can either raise their hand and then unmute, or if people feel more comfortable, they can put it in the chat if they have responses to Naomi's question about kind of what are your thoughts about what you do, or have you been in a similar situation? Edwina, I hope I said your name right.
Yeah, no, you said it correctly. So I've actually had this several times happen with both people just graduating or just entering the job, also with students. And I think their idea of I feel overwhelmed, I'm going to call you and you're going to take care of this. So I've done exactly the same thing that you've done. I've also, in a way, said, okay, I'll come with you and kind of observe and be in the background while you handle the situation. So it really depends on who it is. And that has worked too. I've also stood outside the door, which I know sounds weird, but stood outside the door while they handled the situation. And I think just knowing that a supervisor encourages and not, like you said, coddle is important.
Yeah, thank you so much. I love that. I'm sort of hearing like scaffolding, like you're providing some scaffolding for them to feel empowered and to develop their skills. So thank you. And I'm just going to apologize in advance for if I mispronounce names. Sashim, and please let me know how to pronounce your name correctly.
Hi, yeah, that's how you say my name. Well, first of all, I just want to check if I misheard the person presenting, because I thought that they said that the clinician said this was over their pay grade, but did she say she's in over her head, as the vignette says?
She said it was above her pay grade.
Yeah. So I think one thing that's interesting about community mental health is that, for the most part, we're supporting clinicians who are early career, and there's a lot of acuity in our work immediately. And I wonder if, we could just sort of normalize and support them with the feelings that would come up with being with somebody who is really manic or distressed, and also, to kind of normalize that that's going to happen. And I think that the discussion about scaffolding is really helpful. I mean, I've also sat next to an intern while they were talking with someone who, needed a suicide assessment, so that they could ask the basic questions they needed, but not feel completely on their own in that process. But I think this is a really important, just clinical issue, because, somebody who is very symptomatic needs to be assessed, and, that would be outside of someone's scope who's very early career, but at the same time, that's going to happen all of the time. And part of our role as clinicians is to kind of, sit with our emotional response and get consultation on what's happening. And so I don't know if that makes sense, but I think just really acknowledging that and providing support with the emotional response, but also understanding that this is something that comes up all of the time in our work too.
And just to add to that, I would think, sometimes we have to help people recognize, this is okay, right? Like everything is safe right now. Nobody is, nobody's in danger right now. We don't have to solve this in a second, right? So that we can slow things down a little bit, right? For when we're doing that suicide assessment, right? Like they're here with us now, things are safe, and we're going to talk it through, right? And so that there's time for that. Because I think sometimes there's just like, we got to solve it right now. And, it's not a realistic thought. It's not a helpful or accurate thought.
Yeah. Naomi, did you have any final, did you want to sort of say anything, final words about the case before we move on to our next one?
I just wanted to share that the clinician did say that she gained confidence that day and felt like going forward, even if she felt nervous about working with a client, that she knew that she would have support. And that additionally, so the experience and the support helped contribute to confidence.
Yeah, sounds like a great outcome. And sometimes we have those, and then we also know sometimes not. So let's thank you so much for sharing that. We'll go on to the next scenario, just trying to be mindful of time. This Stacy as composite sort of scenario, I will turn it over to you if that sounds okay.
Yeah, did you just want me to just jump into how I solved or resolved
Sure.
it and then
Yeah,
do questions
maybe
after?
we can just give, maybe we can just pause for, 20 seconds or so for people to read it. Maybe a little bit longer, maybe that's too fast, but
I
we'll
can
just
read it
pause
out loud.
a little bit. What was that?
I don't mind reading it out loud. but
Okay,
do
sure.
You want me to just jump
That-
into
Sure,
how
that'd
we
be great.
resolved it?
Yeah, that'd be great.
Okay. So you've been supervising a provider who has been at the organization for 7 years. She's a devout Catholic and founded the agency's faith-based services program. She has been an excellent employee, uses CBT with fidelity, and has received excellent reviews from clients. Your organization has had an increase in referrals for clients that identify within the LGBTQ+ community. This supervisee admittedly has had no personal or clinical experience with this population, yet she states she is open to working with this population. She begins seeing a teenage client who is questioning their gender identity. In supervision, the clinician comments about how she believes such teens are confused and going through a phase, and that if they don't act on their thoughts and feelings, then eventually the phase will pass. The supervisee acknowledges struggling to reconcile her personal religious beliefs with the client's expressed identity. You present research on best practices for working with gender minorities, but this has not changed her behavior or approach with the client. It is still early in treatment, but if things don't change immediately, the client will not receive adequate services nor gender affirming care. Okay, so what did I do? So after 7 years of supervising her, I knew her really well. So we had already had discussions in the past, easy ones and hard ones. So that had helped. I've always thought the most important thing between a client and a clinician is rapport. And I believe the same thing between supervisees and supervisors. It's that there needs to be a strong rapport and trust so that hard conversations like these can happen. But before she met this client, before the intake, she did complete my in-house LGBTQ cultural humility training. And we also went over the American Psychological Association's guide for practice with transgender and gender nonconforming people in depth, because that was in preparation for this intake. And I just wanted to add that she has a huge heart, this clinician. She wanted to help, but she also said that she felt this internal struggle. So a day or two after the intake, she told me that she had talked to her husband and she had talked to her priest, and then she still felt conflicted. So that day, I remember we discussed specifically the APA guideline number 4. And I'll just read it to you. It states that the provider must be aware of how their attitudes about knowledge of gender identity and gender expression may affect the quality of care they provide transgender and gender nonconforming people and their families. So I actually made a big decision for this supervisee right then and there. And I let her know that at least for the time being, she won't be working with this population. And I made that decision for 3 reasons. One, because she let me know that day that she did have a belief about the community that conflicted with the appropriate and and trans affirmative services that that client was entitled to. And that told me that there was a potential for undue harm to happen. The second reason was because we both felt, her and I, that the client would be better served with another clinician with more experience and knowledge with that community. And the third reason was because she did not think that she had enough experience to be able to honor that client's pronouns and validate their feelings about their identity. So, yeah, I would say it was a hard conversation. It was, but honestly, she understood. And I also validated her feelings and respected her process. And I thanked her for trusting me with her beliefs. And I also want to add that she was still required to take further cultural humility training around working with this community, because you can't always predict what will be disclosed in any given intake or even in treatment later on in the process. So she still needed to continue her training in that area. And she also agreed to follow the agency policies around addressing issues of gender and sexuality when they did come up for her in sessions, and also staff those with me immediately. But these conversations were never about shaming her for her beliefs or her values. They're just open conversations about her needs and the needs of the client. And she admitted to gaining self-awareness and knowledge, and that she had a conflict of interest. She'd said that she had a conflict of interest about it. We were actually able to direct that client to a therapist that was much better able to meet their needs. So I also wanted to say that this does come up, and not just for issues with like this. So I've seen it come up for other reasons. Like, I've had other clinicians come and talk to me about the fact that they've had a personal history of physical abuse in childhood by their mothers, and they have a bias against working with mothers whose children are DCYF in DCYF custody due to physical abuse. And those clinicians also aren't the right fit to work specifically with that population of adult clients. So these are just discussions that need to be had in supervision so that we can make sure that our clients are being seen by the most appropriate and helpful therapists for them, and that we follow the basic principle of do not harm. Okay, so then what would other people maybe do?
So Stacey, thank you so much for that. Really appreciate it. And yeah, these are not easy scenarios. And I think promoting self-awareness is an important role that supervisors play, promoting clinician self-awareness, right? That's really key to sort of ethical, competent practice. Avril noted that it might be interesting for the clinician to consider the presumption that there are not devout Catholics who are also LGBTQ+ identified. And perhaps she could find assistance in talking with folks who hold both demographic identifiers. So that was something that we heard. And then which is, and then she continues, sorry, I didn't see the second part here, that training is insufficient to meet the outcomes we're seeking. Agency culture change is necessary. So that yeah, perhaps having, it sounds like, and Avril, I don't know if you want to jump in and say anything more about that. I don't want to speak for you.
Thanks. Mostly just that we got to think bigger. You know, we have to have the support besides, you know, certain numbers of trainings of hours, you know, that folks need to attend, and that will somehow kind of reach the outcomes we're going for. That's the basic gist. Thanks. Yeah,
thank you. Yeah, it's making me think about, it's almost like, you know, this idea that it has to be a but, and it could be an and, right? There can be
yeah, it's not an either or. It's not either or. Yeah.
That it could be an and, that there could be someone with both identities and sort of having that exposure. And then Naomi, Okay, so organizationally, it sounds like in Naomi's agency, they add a statement to job descriptions or postings that, individuals will be working with diverse populations. And that's certainly a good way to kind of get that out front. And sometimes you can put that, I think, and you still end up in these scenarios. So Norma, would like you to please share.
Oh, I was just going to say that I think it's important for us to not consider this individual's feelings and knowledge about herself as a bad thing. I think,
Definitely not.
there's different individuals who have expertise in different areas. And, one of the things that was often said in like our social work classes was you need to know who and identify who you can work with, right? And so, knowing that about yourself is not, you can provide the training and you can provide those things, but I think, sometimes an individual could work depending on what the need of the individual is. Sometimes it's not about like their sexuality. It could be, their depression, or it could be something, and observing that individual more of like, we're all human, regardless of what it is. But there's other groups of individuals, that we may struggle with, right? So it could be, there's a lot of areas like, sexual offenders, that might be an area that one of us is not comfortable with working. And that doesn't mean it's a bad thing. It just means that that's an area that it's conflicting to the person. Yes, additional training may be helpful, but I think accepting and respecting that. And, I think that when we're choosing not intakes, but individuals, we're looking for what would be the best fit for this client. And so, I mean, if you have a variation of individuals, then maybe that's not a good fit, right? And that's okay. So I don't know, I just wanted to not see it as a negative thing that,
Yeah.
that she knew that she wasn't accepting of it. So
I didn't want it to come across as a negative thing. It was just that
no, I was just saying,
yeah,
I wasn't.
she was able to identify her bias, and she agreed that that wasn't the population for her, but she had other strengths, and she was really capable of working with a lot of populations that I wouldn't even be able to work with. Like faith-based services was her main passion, and she did great work in that area.
Yeah, I've loved this conversation, and just want to make sure we get to our last one before we wrap up for today, but really have appreciated people's thoughts and this conversation. So we'll go to the next slide. And Louisa, I'll turn it over to you.
Great, thanks. Yeah, I just wanted to share an experience I had with an intern. He was a cisgendered white male, and he was an intern and he was attending an online graduate school. He had a kiddo of his own, and counseling and therapy was kind of a second career for him. He had some experiences as a teenager that made him feel like this is what he wanted to do, but he had worked in sales and been quite successful for a while in it. He's very personable and builds rapport very well. But he was a little unsure about what to do with that rapport after he had it, to help clients make active changes and make choices in their life, different choices in their life to move towards what their goals were. And he had very little support from his faculty. He was working, one of his cases was a 12-year-old Black male who was recently placed in an informal guardianship with his maternal aunt and her wife. He had recently been acting out in school, getting sent home, and then he was being rude and disrespectful to his caregivers, admittedly, saying things that you would hope your kid, wouldn't always say. And the aunts would warn him that if he didn't shape up, he'd be sent back to live with his mom, who was active in her addiction and was not able to provide a stable house for him. So thankfully, he seeked out some supervision before going into the next session. And in that time, he tells me that he wants to tell the aunts, or he wants to tell the client, hey, your aunts really care about you. Here are all the signs they care about you. So why are you treating them that way? And that he didn't have many plans to talk to the aunts. Maybe for the sake of time, I'll jump into what I did. I think modeling is such an important piece for every relationship there. And so I started out by noticing his strengths. He is he's very good at building the relationship, at building rapport. It's probably something he did really well in sales, and it served him well here. So how can we use that here? And he genuinely cares about this kiddo. And this kid actually really does care about him based on that rapport that they've built. So really focusing on those strengths, focusing on the strength that because he cares about this, he really wants this kid's behavior to change so that he can live in a safe environment, right? Like those are all really great goals. We all have that goal for the kiddo. So after we talked about those goals and strengths that he has, I asked permission to give him a little bit of feedback about some things that I was seeing in his approach. And I think asking permission is a huge part of being able to talk with the caregivers, for example, right? Validating their goals, talking about how much they care about this kiddo, that they've brought him into their house, and that those are, and that they really want him to shape up because they're worried about his behaviors, right? But also asking permission to help them understand what does it mean to a 12-year-old who has this history of neglect. If you say, if you don't start acting up, I'm gonna, you're gonna be sent away. We're not gonna continue to take care of you, and what that might mean and how that might affect behavior. And so that the aunts can have some idea about, while we understand what their goal is there a way we can do that without shooting ourselves in the foot, which is kind of what we're doing when we say, if you don't shape up, we're sending you back. I also talked with him. I did a little self-disclosure around, I remember one of the things that my internship supervisor told me, which was probably at this point now 22 years ago or something like that. You have to find a way to talk to this kid in a different way than everyone else is in his life, right? People at school are telling him he's not doing the right thing. People at home are telling him he's not doing the right thing. How can you talk to this kiddo differently, in a different way? He's got enough people telling him not to do that. How can we understand what's going on behind that behavior, why he's doing that, and how we can find different ways to reach that goal? So to really take time to understand the kiddo's behavior, instead of just being another adult to tell him not to do that. If that worked, kiddo wouldn't be here. We'd probably be out of a job. So let's find another way to deal with that. And then we talked about and really developed some plans to how he would have a conversation with the aunt. We practiced that. And then we also practiced how he may have a conversation with the kiddo, and what kind of things he could ask about, what kind of ways could he ask questions to move this kiddo towards looking at different options for his behavior, and different ways to meet his goals, which is also what we're going to want the aunts and the kiddo to do, right? Practice. What are some things we can practice in session that will move us towards what we're looking for? And so kind of the parallel process was really strong here. And I think kind of like what we were talking about with Naomi's client, I also wanted him to understand that you're not going to solve this problem in one session, right? This is going to take a while. We're 12 years into this kiddo's life. One session of telling him not to do it isn't going to stop it. We got to take some time to help him move this behavior along.
Yeah.
And I think that was really valuable. It kind of gave him permission to not feel like I have to change it all right now, or I'm not doing a good job.
Yeah, Louisa, oh my gosh, thank you so much. And just feel remiss that we're at time. I know people have to go to other things. I think, you know, what I would hone in on there before we wrap up is the practicing is really using supervision as a way to help clinicians get comfortable doing things with their clients, right? Using the supervision space as a way to practice that, I think is so fantastic, which is what we also want, like you said, our clinicians doing with clients. So Anna has posted the evaluation link in the chat. We would love to hear your feedback, how this was received by you, constructive feedback. We really appreciate everyone's engagement and participation and people's input. And clearly we could have, you know, probably doubled the time and still had plenty to go on. So just want to thank everybody for spending their afternoon with us. And we will be in touch soon, and don't hesitate to reach out to CoLab if you have any additional needs. Thanks again.
Thanks so much, Georgiana. And I'll just add, I saw in the chat that this will be shared on our YouTube and also
Wonderful.
on our website.
Yes.
So I will post a link where all of our webinars are listed, and you should also be getting an automated email once it's posted as well on our YouTube. So getting that in the emails along with our evaluation.
And thank you to our wonderful panelists. I'm going to leave it there.
Thank you.
Bye-bye.